screen with all of you. Give me a second here. But I've been asked to speak along with Ben Schneider about something called the Childhood Liver Disease Research Network. And I don't know why it's taking so long for my screen to share, but it says it's sharing. But we've been asked to speak about the Childhood Liver Disease Research Network, and its acronym is ChilDReN. And since this is taking so long, let me stop that and try again. Unusual for this to take that long.
It looks okay from here on. I hadn't advanced. I don't know whether you tried advancing it, but
so you will, now it says you can see it. Okay.
Yep.
Dr. Sokol, can you hear me?
Hello.
Hi, it's Emily.
Yes, Emily.
Very sorry for the hybrid meeting challenges. Can't proceed. Before you go on, before Richard leaves, because I never know when Richard's going to stay and leave. I just wanted to present him with his plaque for his service on our medical advisory board and thank him for all that he's done for the community. So Richard, Dr. Thompson, we will be sending you a plaque in the mail, and thank you.
You're extremely kind, Emily. Thank you very much indeed. It's my complete pleasure to be here. I'm sorry I'm not there physically.
We'll get you next time. Dr. Sokol, I will turn it to you. You're able to share your screen. We see your screen. Are you able to advance your slides now?
Should be able to.
Wonderful.
Advance.
Yep. And I guess I'm going to take the opportunity, so there's no delay later, to also present you, Dr. Sokol, with your plaque for your service. Also, advisory board, our medical advisory board from the beginning. So thank you as well, and thank you for being here. And now I will let you get on with your presentation.
All right. Well, thank you. Well, back in year 2000, we had many challenges related to rare childhood liver diseases, such as single center studies where each center saw a handful of new cases a year could really never move science forward quickly enough to make major discoveries and certainly to develop and test new treatments. We had this unprecedented ability because of the Human Genome Project and other advances in technology to understand and discover causes of disease and develop new therapeutics. Yet, although rare, as a group, these cholestatic liver diseases, and all of them together is about 1 in 2,500 live births, all of them, as you all know, take a huge toll on families, are the leading indications as a group for liver transplantation in children. And at that time, we really had no FDA-approved therapies and probably no effective therapies, even if they weren't FDA-approved. So back then, a group of us spoke to leadership at NIH, and lo and behold, in 2002, NIDDK, National Institute of Diabetes, Digestive, and Kidney Disease, formed something called the Biliary Atresia Research Consortium, or BARC. There were eventually 10 clinical sites, a data coordinating center, and the goal was to study biliary atresia, what was called idiopathic neonatal hepatitis. 2 years later, in response to an NIH new program called the Rare Disease Clinical Research Network, we were funded to form the Cholestatic Liver Disease Consortium. And this actually was the same 10 sites that were in BARC. And we were charged to study 5 intrahepatic liver diseases, including PFIC. And these went on till 2009 separately. And then in 2008, a new network, the Cystic Fibrosis Liver Disease Network, was funded by the CF Foundation and NIDDK to study CF-associated liver disease and other cholestatic liver disease. So this all culminated in 2009 for BARC, CLIC, and ChilDReN, BARC, CLIC, and CFLD to form ChilDReN. So they got married and the results were ChilDReN. And ChilDReN was initially 16 sites funded by NIDDK, but also the CF Foundation and the Alpha-1 Foundation for Alpha-1 Antitrypsin Deficiency supported the network as well. And this network now is going on its 21st year. We're funded through 2024. It's 14 sites. There's 3 more for CF. This includes a site in Canada, in Toronto, and Richard being our genetics genomics core leader in King's College. This is truly now an international network. And once again, we're funded mainly by these 3 sources. And we can't say enough of the support of Ed Du, Avril Shirker, and previously Pat Roebuck at NIDDK to continue the funding and support and expansion of this network. So ChilDReN studies 9 different cholestatic liver diseases, all except perhaps biliary atresia being genetic, and there's some genetic forms of biliary atresia. And you can see the list here, and number 5 is PFIC and benign recurrent intrahepatic cholestasis, or BRIC. I don't know if Richard mentioned BRIC, probably milder genetic forms of the PFIC genes, or perhaps some heterozygote states, but usually with a later onset and with intermittent symptoms. We all believe it's a continuum, truthfully, between PFIC and BRIC. Again, the same genetic disease, but just with different phenotypes. And you can see the other diseases. I might mention that primary sclerosing cholangitis, PSC, is the most recent disease, and we just launched a large study in North America of this disease in December of 2021. Here's where all of our centers are located, and I'm happy to say we're really from East Coast to West Coast, north to south. Virtually every one of these centers is in a major children's hospital or a major pediatric service in a large adult hospital. Each site, though, is competed separately. And it is important to know that every 5 years, we all have to submit a grant, and we are then chosen or not chosen to remain in the network. The Data Coordinating Center is in Ann Arbor, Michigan, and the NIH in Bethesda is obviously key to this. Please note that our website is childrennetwork.org if you want to find us, and there's lots of information about the diseases and all of our publications and other information on the website. This is how it's organized. I don't know that we need to go into great detail, but I did want to point out that we have an administration core that oversees some of our activities. Obviously, all of our clinical sites are critical. A data coordinating center that manages all the data, the protocols, the analytics, and others. We have data and specimen repositories that are absolutely critical for our network and supported through a different granting mechanism by NIDDK. And then, as every clinical research study has, we have a data and safety monitoring board that NIDDK sets up and manages along with the data coordinating center. So this, very briefly, is how we're organized. We do have several cores which are very important. Our genomics genetics core, and this involves multiple people. And again, I mentioned Richard, Nancy Spinner, Laura Bull, Saul Carpin, Stephen Guthrie, but others on our genomics committee. We have a large portal hypertension fibrosis initiative that Ben Schneider and Lee Bass have overseen. Again, many others involved. And then we also have a mitochondrial respiratory chain analysis core here in Denver that's essential for our mitochondrial hepatopathy studies. We have loads of committees, but when you have an organization this large, you have to really have policies, procedures, and follow these policies and procedures in order to facilitate the collaboration, which is absolutely essential for our network to function. Each of the children's hospitals has its own liver program, its own liver transplant program. Our idea isn't to usurp any of their authority, but to get them to all play in the sand together and think of the outcome of our patients as the primary goal of the network and not the outcome of their individual hospital or programs. So our steering committee and our executive committee really oversee much of the network duties, but you could see that we have many other committees. I also would mention that our disease-specific working groups are also a key feature of this network, and these working groups meet usually virtually now, previously in person, to discuss new findings, new ideas, new initiatives for that specific disease that they're overseeing. And we have a PFIC working group. And then we also have a protocol committee that oversees the protocol in which the PFIC patients are enrolled. We collect specimens which differentiate us from some of the other networks. And right now in the repository, we really have well over 200,000 specimens. And this includes serum, plasma, urine, liver tissue, liver slides, and other tissues. We also collect DNA on all enrolled patients and ideally on their two parents so that we can do genetic studies using what's called trios. And right now we have over 7,500 patients who we have DNA on. And in terms of tissues, liver biopsies, bile ducts, lymph nodes, gallbladders, we have over 3,400 specimens in the repository. Many of these have been utilized for numerous studies. And another unique feature, particularly for NIH, is that we have a patient advocacy group committee that includes at least 8 patient advocacy groups. And you can see that the PFIC network is on our list. Previously, we enlisted pfic.org. And the patient advocacy groups, besides meeting virtually several times a year, I can hear somebody. Please mute yourself. Our patient advocacy groups, we really access and appreciate their input regarding development of our protocols, make sure our endpoints and our data collection and meet the needs of our patients. Please mute yourself. I don't know, Emily, if you can mute everybody except me. And we also then have our patient advocacy groups review our consent forms before they're finalized. And then we appreciate advertising our studies and helping us recruit. And even some patient advocacy groups like the CF Foundation provides additional data to the network on pulmonary functions, et cetera, that they collect on patients with cystic fibrosis. Finally, I just wanted to once again acknowledge the Alpha One Foundation and the CF Foundation provide ongoing funding to help support some of the network activities along with NIH. So this really is a very large collaboration. So the aims of the ChilDReN studies, and again, I want to emphasize, these are almost all longitudinal, long-term observational studies. The aims are to develop new knowledge around the etiology, the genetics, epidemiology, pathogenesis, natural history, and outcomes of these rare diseases. That's a tall order, but I think almost to a disease, we have achieved much of that. We also thought it was very important back in 2000, it's even more important now, to understand genotype-phenotype relationships, particularly with our hopefully future ability to really personalize therapy to each individual patient. We also had a goal to develop new diagnostics, biomarkers, and disease endpoints. We had quite a bit of work looking at neurodevelopmental and quality of life outcomes, and we continue to collect some of these data. And then very importantly, we wanted to be study ready, trial ready, with a large group of enthusiastic families to be ready to enroll in clinical trials. And the network itself has developed several clinical trials, and we've collaborated with the pharmaceutical industry in other clinical trials. So very quickly, I'll list our studies. This probe is a longitudinal study of children, usually as an infant, as soon as they're diagnosed with cholestasis, but before we know their underlying cause. BASIC is a similar study of older infants and children. Not sure why it came out great. LOGIC is our study that includes 5 genetic causes of intrahepatic cholestasis. And this is the study that most of the children with PFIC are enrolled in. There you go. MitoHep is a study of mitochondrial hepatopathies. PUSH is an evaluation of ultrasound in cystic fibrosis. We had 2 randomized controlled studies, one of steroids in biliary atresia and another phase 1/2A study of IVIG in biliary atresia. And then studies that you'll hear more about, I'm sure today, ITCH and IMAGINE-2 were studies conducted in our network to evaluate the IBAT or ASBT inhibitors. This was a study in Alagille syndrome, and the results of ITCH are published, actually the first pediatric trial of any of the IBAT inhibitors. And the data from IMAGINE-2 and ITCH have been combined with some of Richard's studies, and this paper is now in press in Hepatology Communications. We have a big study of FibroScan, the elastography, the non-invasive way to assess liver stiffness. And some of these data are published and many more are ongoing. And then there's studies of 2 types of elastography in cystic fibrosis, elastic and MRE. So just to summarize where our studies are, we believe we have the largest cohorts in the world probably of children who have been identified with these rare diseases and are followed longitudinally up until the time of transplant, and in some studies beyond transplant. So we have over 2,500 children with biliary atresia, 445 with Alagille, 550 with alpha-1. And for PFIC and BRIC, we as of March, we had 344 patients enrolled in our network. And although that sounds like a lot, this is a group of at least 5 or 6 different diseases. And you may hear from Ben Schneider and Hank John Vercotti why, even with our large number, we needed to collaborate with NAPID in order to really understand genotype, phenotype correlations. And then you can see the numbers with the other diseases. So overall, we are following over 4,600 children, or at least have data on 4,600 children with these rare diseases. So in summary, we believe ChilDReN is a fine example of how collaboration between the NIH, universities, industry, certainly our patients and their families who we couldn't study the disease without their involvement, the patient advocacy groups and our hospitals, how all of them working together can support our network and lead to new discoveries, translation of these discoveries into diagnostics and therapies, and hopefully in the end, improved outcomes and cures for the children affected by the diseases that we study. So that's my last slide. I am going to stop sharing, and I'd like to turn this over to Ben Schneider that's going to provide you with more information of some of the studies conducted in children. So Ben? I believe Ben's in person.
Right now.
Ron, that was a great presentation. Congratulations. Those on the call or on the Zoom meeting here in Pittsburgh. Ron has been an incredible leader for children, park, play, children, whatever else. This has been over 20 years of his incredible work and leadership that's made this happen. So we're all very grateful to you, Ron. Thank you. Great honor for me to be here. Great to me have an opportunity to come back to Pittsburgh. It's good. I wore my Pens jersey on the way up here, so take advantage of the last game of the season. Sorry, that's you don't care about that, I guess. And I'd like to congratulate your group for putting this together. This is a tremendous first in-person meeting. So well done. Anyway, I'm going to sort of drill down a bit on the studies that have been done in children. They're focused on PFIC. A lot of acronyms. I apologize, but so be it. So we'll be talking about PFIC and the logic study, presenting this on behalf of children. Next slide. Is there a pointer? Will this work for people at home? No. No. It won't work for people at home, but you can move it up the screen. All right. So as you heard, the logic study, which stands for Longitudinal Study of Genetic Causes of Intrahepatic Cholestasis. We spend a lot of time figuring out clever acronyms for these things, and you can imagine what went into using children so anyway, that's a whole other story. But so this was initiated in 2007. So it's been in place for now 15 years. And you heard about from Ron, the diseases that are studied within logic, and it includes progressive familial lymphatic cholestasis. And yet, you have to think back in 2007, it was a very different landscape. And so, we were still, and many are still using PFIC 1, 2, 3, et cetera, which probably all of you would prefer we go back to rather than the terms that we use. So we started at sort of a different phase, and there are several groups in logic. The first group, group 1, are children who are identified with neonatal cholestasis. So they have jaundice or something else in the newborn period, and they're enrolled in a specific study. And they may later be found to have PFIC. So they may not be known to have PFIC at the time, but they're enrolled because they have this neonatal cholestasis. Most of the children in logic are in group 2. And this is basically what we call a cross-sectional study. So we don't care where you are in your disease course. We'd like to enroll you in a study, and you may be 2 years old, you may be 5, you may be 18 years old, and we start you in the study at that point in time. So it gets a little complicated because we're not starting with everybody at the beginning of their disease. We're starting with them somewhere in their course. And then because we're very interested in both the genetics of these diseases, but also in what may happen afterwards, we also enrolled patients who had liver transplants for their disease to look at the genetics, but also look at what would be going on after liver transplant. Kathy Loomis is going to, I think, be presenting tomorrow, is the chair of the logic protocol, which is for overall for the various different diseases, of which PFIC is one. Next slide. So in logic, there is, at the time of enrollment, you get entry data. So you sit down with the family, get information, find out everything that went on before, what's going on now, and then collect a number of things, including history, physical exam, laboratory studies, and also potentially get follow-up data each year. So patients are seen annually, and at the follow-up visit, physical history, what happened last year, and importantly, whatever laboratory studies are obtained as part of routine care. So we don't do special research labs with a few exceptions. So this is where things get a little complicated because, one clinician may say, I want 50 labs every time I see you. Another clinician may say, I just want 3. And so we don't have the same labs on everybody, but there's fairly good consistency about this. Research genetics. So when we started, there was not routine availability for genetic testing for PFIC. So we were obtaining samples, and it was very complicated because we were doing genetics, and there was a lot of discussion about whether we could release the results or not because it was a research test, and we won't go into all of that. But it's very different now compared to what it was when we started. There's the biobank, which Ron talked about. Lots of different samples are collected. We also did some studies on bone density. What's called a DEXA, and I'm going to show you a little bit of information about that. We were interested in hearing, so audiology was done, in particular in patients with Alagille syndrome and PFIC, because as some of you know, hearing problems are associated with some of the forms of PFIC. And we were very interested in development and quality of life. So developmental assessments and health-related quality of life were done at different points in time during the study. Next slide. So this is generally true. And the major aims, as Ron talked about in the LOGIC study particularly, are to understand the clinical picture and the natural history of the disease, look at growth, have a biorepository for future studies, samples of serum, genetic, DNA samples, etc., for all kinds of studies that people may want to do. A real focus on genotype, phenotype, what's your genetic problem, what's the genetics, and what does that translate into a clinical issue? And then there was an interest in bone health, and that was why the DEXAs were being done, because bones can be affected by liver disease and lack of bile flow and lack of vitamin D, etc. And the LOGIC study is registered on clinicaltrials.gov. If I can figure this thing out. No way. Figure this out while I'm doing this talk. And you can find information on clinicaltrials.gov at that number if you want more information about this study or any other study for that matter. Next slide. So now let me move from LOGIC, which is the overarching protocol, to the PFIC protocol, which is one of the diseases that's being studied within LOGIC. So to be included, to be considered as PFIC and to be eligible to be in the study, there were several we call inclusion criteria. So first, if you had a genetically confirmed diagnosis, then you qualified for being in this. Now remember, at the beginning, people weren't getting routine genetic testing, so that was not the way people got enrolled. But we also were aware that there were limitations on genetics. There were diseases for which we didn't have a genetic understanding. So we wanted to make the entry criteria very broad. So we would get patients with unknown diseases in the study who had cholestasis. So we may be able to, in the future, understand the genetics, and that was one of the goals of the study. So if you had chronic liver disease, and it listed the criteria there, and you had cholestasis, and we had a broad definition of cholestasis. So that could be high serum bile acids, a high direct bilirubin level, or if you had fat soluble vitamin deficiency that wasn't explained for some reason, or you had pruritus that wasn't explained, those could be things that would indicate cholestasis that would make you eligible. We didn't want to study known diseases, so we excluded known diseases. So if you had biliary atresia, we didn't, for this study, we didn't want you in the study. If you have sclerosing cholangitis, you shouldn't be in the study. So we wanted to study the forms of cholestasis that were either these genetic diseases or ones that were unknown. Next slide. The primary outcomes were major events, so liver transplant, death, development of fluid in the abdomen, ascites, problems with growth, the liver not working properly, or complications like variceal hemorrhage, bleeding in the intestine from scarring of the liver and portal hypertension. Next slide. But there were lots of other outcomes that we wanted to look at. Were kids listed for transplant? What were the PELD and MELD scores, which were the scores of the severity of the disease for listing for transplant? What was their neurodevelopmental outcome? What was the quality of life, both for the child and for the family, their growth, their bone mineral density, and then looking at hearing as a potential manifestation of some of these diseases. Next slide. So let's see. Unfortunately, we cut off the very top here, I guess. Maybe on this one I can see it. So, so this is information from Paula Purtle, who's back there, who's the lead author on this paper. And this was, I'm presenting this so you get a feel for the complexities of studying PFIC in our network, which includes as Ron told you, 15, 16 centers which specialize in liver disease in children. And for this particular study, this was enrollment from November of 2007 to December of 2013. We're talking about 6 years of enrollment of children at these sites, at these 15 or 16 sites, meeting the criteria for PFIC. So we have, at the top, there are 209 kids who have met the PFIC criteria. So you move down the first branch, and there's about 40 or so who, for one reason or another, didn't get genetic testing. The families didn't want genetic testing, which for whatever reason. So automatically, if you're looking at specific diseases, you can't, those patients aren't going to help us with these analyses. So you've got 171 who had genetic testing done. That was a research genetic testing. And of those 171, 59, you see on the left there, we didn't find a mutation in PFIC 1, 2, or 3. Good news, bad news. Good news, if you're trying to find new causes of disease, is a group of 59 kids who may provide some great insights. But bad news, those kids don't know what they have, and families don't know. And the bad news is we really can't study them for this kind of study where we're looking at specific diseases. So we've got 112 kids who had mutations in either FIC1, BSEP, NDR3, PFIC 1, 2, and 3, the diseases that were known genetically at the time we started the study. So now, remember, 6, 7 years, 15 centers, 210, and we're already starting to make smaller and smaller boxes. These are, these are groups that make sense to understand the disease. And you can see as we move down this, I guess I don't. So we'll go back. No, we're really going ahead. Okay, perfect. But what you're going to see as we go down here is groupings that make sense from a clinical and a scientific perspective start to get this group into smaller and smaller groups. So now you start to divide up, and you've got 30, a third or so who have FIC1 or PFIC1, 60 or so PFIC2, and then 19 with NDR3 or PFIC3 disease. Now, some of the kids only had one mutation. You're supposed to have 2. So the question is, did study those or not? We decided in this study we would not study the children who had 1 mutation because we weren't sure if the disease was purely from that. So then you start to get rid of more of the patients that potentially could be studied. Next slide. Now, of those, we end up now with 26 children who have FIC1 disease. 2 of them were enrolled post-transplant. So you don't really learn so much about the disease, you just know that they came to transplant. There's a higher percentage of children who had transplants for BSEP disease, not as many for NDR3, but importantly, some of these children had biliary diversions, surgery to treat the cholestasis. And so now you subdivide these. The bottom line on all of this is, even though you do the study for 6, 7 years with 15 sites, by the time you divide this up into the relevant categories, you're looking at, groups of 10, 15, which is great, but it does limit what you can learn despite all of this. Next slide. So just to give you a flavor of what this analysis turned out, and I think Paul's going to show you this again at some point in time, when children were enrolled in the study, we looked at what kind of problems did they have at the time of enrollment. Now remember, they're enrolled at all different ages. So a child who's 6 months old probably has fortunately not had time to develop some of these problems. So you have to be careful about looking at this kind of information. But not surprisingly, pruritus, itching, is a hallmark. And so very common, certainly in PFIC1 and 2, maybe not so much in NDR3 disease. And you can see all the other things. And the bottom line is there are a lot of different clinical problems that are associated with these. Some are very specific to PFIC, some are typical manifestations of chronic liver disease. Next slide. So this is sort of a little bit of a unique aspect of the way the study was done as far as analyzing the data, because all the kids came in at different ages. And if you set time 0 as when they were enrolled, it would probably not be very informative because you have a 2-year-old and a 15-year-old all at time 0. So what we did instead was we analyzed the data based on their age at enrollment as opposed to the time of enrollment. And so this is the way this is shown on this graph. And this is the graph, for instance, for ALT. It's one of the markers on the blood test that shows liver injury. And the question is, what is the ALT over time for a patient who has PFIC? Well, in this study, we don't have a bunch of kids being followed for 20 years, but we have kids at different ages. And if you look at this, it gives you a flavor, not an exact answer, for what happens to this lab test over time for this disease. Because we know the disease starts at birth in all these kids. So you can look, for instance, that in children who have BSEP disease, the middle panel, the ALT is much higher in the first year or so of life and then comes down. And it's more variable in NBR3 disease. It gives us information about the disease. Now, we're not looking at specific genotypes, and there's some of these kids have had biliary diversion, some on ursodeoxycholic acid. So it gets to be a fairly complicated thing to look at. Next slide. What am I doing on time? Ooh, okay. This is looking at weight as a marker of nutritional status. Now, this is looking at using what's called a Z-score. So a Z-score is sort of a statistical parameter. A Z-score of 0 means you're in the middle. You're at the median. A Z-score of 2 means you're 2 standard deviations higher than the median. So my Z-score for weight is probably above 0, unfortunately. But so be it. What you don't want to be is negative, which means your weight is much lower than it's supposed to be for your age. And this gets complicated based on the disease. But again, you get a flavor of where the Z-scores are for these children at different ages. And you get a flavor that in pick one disease, there's more problems with weight early on in life. Not so much in BSEP disease and NBR3 disease. Now, these patients may be getting NG2 feeding, special nutrition. So, there's interventions that are going on for these children. Next slide. Platelet count. So platelet count is something, it's a marker, it's a blood test, and platelets tend to be lower when your liver is more scarred and it's more severe. So looking at the platelet counts give us a sense of things. And interestingly, and the line there is sort of the normal level. And you can see the platelet counts in generally are normal, in the normal range for kids with PFIC1, BSEP disease. Sorry, I'm just going back and forth. I'm not sure which term you like. But you see more advanced disease in patients with PFIC3 or NBR3 disease. So again, these graphs just give you a flavor of what the disease looks like over time without necessarily following somebody for 20 years over time. Next slide. So just want to give you a sense, these studies were going on that allowed people to do other things. So for instance, this is the DEXA study looking at bone health that was done, led by Kathy Looms, who again you'll hear from later. And I'll maybe put Kathy on the spot and have her explain this because I still don't understand this study. Understanding DEXAs and bone health in kids is very difficult. But interestingly, we focus on vitamin D, et cetera, and the relationships to things like vitamin D were not so clear. What we did see is that children who had, there was diminished bone density in both Alagille and cholestasis, and this is called CIC because we weren't looking at specific genotypes, cholestatic, intrahepatic cholestasis. But it's when you adjust for patients' size, the changes in bone health are not as bad as one would think. Next slide. Health-related quality of life. This is a study Benita Kamath published in the Journal of Pediatrics in 2015, and again showing diminished quality of life. And I can't get into all the details here in children with both Alagille syndrome and more severe in Alagille syndrome compared to PFIC, and not as severe in alpha-1 antitrypsin deficiency. Next slide. Neurodevelopmental status. Again, very important, selected number of families that were willing to go through all the neurodevelopmental testing. And I would say for this group, in the middle column there is PFIC, and the distribution relative to normative data for the general population is fairly similar. So certainly there's some kids who have more problems than others, but in general, there's not a problem with neurodevelopmental outcomes in this cohort in PFIC. Next slide. There were kids that we didn't know what they had, and we had the ability, we had DNA available. And so you can see two papers that came out that took advantage of samples from our network to identify TJP2, you heard about as a cause, and US53, both of which you can see Richard Thompson, senior author on both of those studies. Next slide. So in summary, I hope I give you a sense there is, this is a prospective longitudinal, there's value in having this prospective longitudinal clinical metadata. So lots of different kinds of clinical data and a related biorepository of samples that you can put together to understand PFIC. I don't have to tell you this, but this is a really complicated disease, a group of diseases. And so we are studying multiple diseases with all sorts of different permutations. And in spite of 15 plus years and more than 15 centers, there are limitations in our ability to study these ultra rare diseases. And this is a great segue because as a result of this, we are actively doing our work, but recognize that it's really important for us to collaborate with the rest of the world to understand PFIC. And I think that is my last one. Great. Is that my last one? Yep, that's my favorite. So anyway, so that's my segue.